like to thank the directors and the scientific committee for allowing us this opportunity to present our data. And I'd like to thank everyone for sticking around to listen to it. So we're going to shift a little bit from the last presentation and actually look at some molecular characteristics that may help us decide what might be some therapeutic treatment strategies in kids with heart failure. So our center is a heart failure transplant program, and in the US at least, most of these programs are closely associated with adult heart failure transplant programs, and so many of their treatment paradigms come from what is done in the respective adult center. There really are no Class A evidence-based treatment strategies for children with heart failure. And most of the treatment strategies are based on expert consensus. And in this lack of clinical data is actually more remarkable in the lack of molecular data or molecular understanding of the mechanisms that might underlie heart failure in children. There is a unifying feature between adults and children with heart failure in that they have elevated sympathetic nervous system activation, and norepinephrine levels are elevated, and it seems to be those elevations are related to the class of heart failure, and in both populations it seems to portend to outcomes as well, so higher norepi levels are associated with worse outcomes. Advanced medical therapy for these two groups does not appear to impart similar benefit between the adults and children. We know in adults with the advent of ACE inhibitor and beta blocker aldosterone antagonist therapy, there has been a significant improvement in all-cause mortality demonstrated here. This was a study that looked at two cohorts, one from the early 1990s, and another adult cohort from around 2006 to 2009. And as the medical therapy improved, the all-cause mortality rate decreased, and this was regardless of whether the patients had ICDs implanted or not. So we think that this is likely due to advancing in medical management. In contrast, this is from Jeff Tobin's group in Cincinnati, where they did a very similar study looking at two cohorts. One was a retrospective retrospective cohort from the early 1990s, and then a prospectively followed cohort from the late 90s and early 2000s. And what they found when they looked at these cohorts was that there was no improvement in outcome in spite of more aggressive medical therapy with ACE inhibitors and beta blockers. In a similar fashion, Paul Cantor's group at Sick Kids in Toronto looked at their experience from the DIG and diuretics era, here in the black, to ACE inhibitors and beta blockers. And while they found that medical therapy of children with heart failure did improve outcomes over those that had no medical management, they did not find any difference in response to these escalating therapies. Our center and Mark Busick participated in this study run by Bob Shaddy at Penn, where they actually did a multi-center randomized clinical trial of beta blocker therapy in kids with heart failure. And to my knowledge, this is probably the most extensive beta blocker trial in children with heart failure. And what they did was randomize children to no therapy or two escalating doses of carvedilol. And in this study, they found no clinical benefit of treatment of these children with heart failure. So taking this data all together, we hypothesized that there may be age-related differences in the adaptation of the beta-adrenergic system to heart failure that contribute to these clinical differences in the response to therapy. And because we have expertise in the adrenergic system and heart failure, we thought that we would focus on this response to beta blocker therapy. At our institution, we have a fairly large biobank of explanted hearts. We have over 250 pediatric hearts and over 900 adult hearts that have been frozen with molecular grade methods. But for this study, we chose to study adults and children with idiopathic dilated cardiomyopathy. There were no ischemic heart disease patients in the adults and no congenital heart disease patients. So we've tried to focus on as homogeneous a population as possible. And then our donor samples, our non-failing samples, are those that were not implanted for technical reasons. This is just a summary of what a recent subject characteristics assessment of the tissue for our sample. You can see that the kids were fairly well age-matched, as were the adults. The ejection fractions were significantly depressed in both groups, and here is some of the medical management. It's important to point out that we have tried to start with studying pediatric subjects that are less than or equal to 12 years of age, thinking that at some point in time there must be some transition from a pediatric phenotype to an adult phenotype. So if we wanted to really understand what was going on in a pediatric patient, we needed to look before we start seeing any of this confounding. A quick reminder of the beta-adrenergic pathways. The beta-1 and beta-2 receptors are the two primary receptors in the heart. It's felt that the beta-1 is primarily responsible for the pathologic changes with activation of cyclic AMP and pKa and CAM kinase. The beta-2 pathway is thought to be a pro-survival pathway, and there is some crossover between these two pathways. So we started our assessment of what's going on in the pediatric heart by looking at receptor expression. We did this using a radioligand protein binding assay that's been well established in the adult population. And what we were able to reproduce were a number of the adult changes, which we think validates our ability to do this assay. With heart failure, it's known that total beta receptor expression decreases. And this is primarily due to a decrease in the beta-1 receptor, with no significant change in beta-2 receptor expression. We've also been able to demonstrate the age-dependent decrease in total beta receptor expression in the non-failing hearts. And what we've shown for the first time is that there's a decrease in total beta receptor expression in the patients with the idiopathic dilated cardiomyopathy, and that this is due to a downregulation of both the beta-1 and the beta-2 receptor subtypes in the pediatric hearts. After seeing these differences, we decided to do an assessment of some of the downstream pathways from the beta-1 receptor, since this is the one that's most well characterized and thought to be responsible for many of the pathologic changes. Just to point out where we have looked before we actually get to the data, we've looked straight downstream here in the pKa pathway at cyclic AMP. We've also looked at protein kinase A, phosphorylation of phospholamban, one of the calcium regulatory proteins. We've also looked at CAM kinase, phosphorylation of phospholamban at a different site. And it's thought that with chronic heart failure, CAM kinase activation actually increases phosphatase expression, so we've looked at several phosphatases. Finally, we've looked at a kind of final common pathway with expression of the pathologic gene program. So let's start with cyclic AMP expression. It's known in the adult heart that downregulation and desensitization of the beta-1 receptor leads to a decrease in cyclic AMP generation. We've found a similar decrease, although this is blunted, in the pediatric heart. Because cyclic AMP is metabolized by phosphodiesterase, we recently started looking at the phosphodiesterase system and have found that this blunting in the pediatric heart is likely due to a unique effect of phosphodiesterase inhibition in these failing idiopathic dilated hearts. In the adult heart, phosphodiesterase inhibition does not appear to increase cyclic AMP generation, whereas we see a significant increase in cyclic AMP in the failing pediatric hearts that are treated with milrinone. Looking at some of the other calcium regulatory effects, phospholamban is known to be influenced by pKa and CAM kinase downstream from the beta-1 receptor, and dephosphorylation of this inhibits the SR calcium ATPase, decreasing SR calcium content. It's been previously demonstrated that serine-16 phosphorylation, so this is the pKa site, is decreased in the failing adult heart, and we found no significant difference in phosphorylation at this site in the pediatric heart. As I previously mentioned, CAM kinase also can phosphorylate this protein at a different site, threonine 17, but in adult heart failure at least, CAM kinase is thought to increase phosphatase expression and thereby produces a decrease in phosphorylation at this site, which is demonstrated here. In the pediatric hearts, again, we found no significant difference in phosphorylation at this site, suggesting that not only are there differences at the receptor level, but there are also additional functional differences intracellularly. Since phosphatases are thought to influence phosphorylation at the threonine 17 site, we did an interrogation of gene expression of the two phosphatases that are primarily responsible, phosphatase 2A, and of the phosphatase 1s, phosphatase 1 beta are the main ones thought to be responsible for changes in phosphorylation of phospholamban. What we found was that in the adult hearts, there was an increase in phosphatase expression that was not demonstrated in the failing pediatric heart. Taking a final look at this common pathway, we looked at pathologic gene expression. These are a genetic program that is almost universally expressed with heart failure in the adults. We see a decrease in alpha-myosin heavy chain expression. In general, beta-myosin heavy chain increases at the protein level. There is an upregulation, pretty robust upregulation of the natriuretic peptides ANP and BNP, and the SR calcium ATPase is decreased, as is connexin 43, the major gap junction protein. In the pediatric hearts, we saw a number of similarities, such as in the adult isoforms of alpha-myosin heavy chain and the SR calcium ATPase, but several of these genes were not regulated in a similar fashion to their adult counterparts. The increase in natriuretic peptides was either blunted or completely abolished in the pediatric heart with heart failure, and connexin 43 actually had an increase in expression compared to the decrease in the adult population. Just to show that this is not just at the gene level, but also at the protein level, the downregulation in gene expression of alpha-myosin heavy chain in the pediatric hearts was reproduced here by Western blotting. So in summary, I think that we feel that children with heart failure have unique clinical and molecular characteristics from adults. They appear to lack some of the clinical benefit from advanced medical therapy. Data that I didn't show you is, in our experience, they have very few ventricular arrhythmias and seem to respond quite well to phosphodiesterase inhibition without the need for primary prevention ICDs. We've demonstrated that there is lower beta-1 and beta-2 subtype adrenergic receptor expression, and that children with heart failure have lower cyclic AMP levels, but these can be augmented in response to phosphodiesterase inhibitor therapy. There's maintenance of phosphorylation of phospholamban at both the pKa and calcium and CAM kinase sites, and this may influence SR calcium loading. There's no increase in phosphatase expression, and there are unique aspects to this pathologic gene expression profile. So a couple clinical implications before I'm done. We think that extrapolation of adult therapy to the pediatric population really needs to be done with some caution. A better understanding of molecular mechanisms of heart failure in children is necessary for evidence-based therapy, difficult though this is. And it will really remain difficult to perform intervention trials in children because this is a very small population compared to the adult population and is designated as a vulnerable patient group. There are no animal models of pediatric diseases, and so I think the development of these will be important for further characterizing the mechanisms of disease. And we have some molecular data that suggests that maybe a chronic use of phosphodiesterase inhibition will be useful as a bridge to recovery, and that perhaps beta-1 selective blockade rather than non-selective therapy with carvedilol would have some clinical benefit. Thank you.
Yes, thank you for the lecture. I have a practical question. I'm an adult cardiologist in a double meaning of that word, but I follow some pediatric patients, and it's very seldom that pediatric patients are ischemic, but I'm following one girl that had a dissection of her LAD at age 9. Her EF went down to 2%, and she recovered. So I've been following her for 1.5 years, and I have been treating her like an adult. I have been giving her beta blockers and ACE blockers, and now that her pressure is stabilizing more, and she's up to an EF of about 45 now. And I even plan to add eplerenone. How would you have treated this patient? Would you have treated her as I do, like an adult ischemic heart patient?
Well, I think that's a great question, and I should have had a full disclosure when I started. I'm not a pediatric cardiologist, so we have a pediatric cardiologist that works with our group, but I think we don't have any good evidence on that specific subtype. I think if you look at Dr. Shaddy's trial with carvedilol, he took all comers. And it just had to be a failing systemic ventricle. But if you look in their placebo group, they had a 50% recovery rate spontaneously. So I think it's a little bit difficult to know what to do in children because, unlike adults, there does appear to be a large spontaneous recovery rate. But I think it's probably reasonable to treat the patient the way you did. I would assume that there would be some scar in that patient's heart. One of the things that we have found, and I might be interested in knowing what some other pediatric cardiologists' findings are, is that there's very little scarring by histopathology in our idiopathic dilated failing pediatric heart. And so I'm wondering if that may be one of the things that allows children to have a higher spontaneous recovery rate, and maybe why beta blocker therapy isn't as beneficial. Did you put a defibrillator in? No?
No, she recovered quite fast.
Right.
Yeah, there is another question here. Professor Yacoub?
At the risk of repeating myself, the 50% who do not recover, they just need time. Mm-hmm. And now we're starting to have pediatric VADs for longer term. I mean, you saw the thing in New England recently with the use of the Berlin heart, but there are others coming mm-hmm. down the line. So just what I said earlier, I mean, rather than leave them die because you don't have hearts, or transplant them with orthotopic. If you do heterotopic, you will expand markedly the donor pool, but nowadays we do have the VADs. Mm-hmm. So VADs with all your lovely medical treatment might be just the way to go. What do you think?
Yeah, so we have done some VADs in patients, but usually as a bridge to transplant. And we haven't seen a lot of recovery in those hearts that have gotten VADs. One of the things that we have started to do is collect the VAD core, and then we collect the heart at the time of transplant. And so we should be able to do some of those comparison studies that people have done to see what unloading of the heart does. One of the things that we find interesting about this phosphodiesterase inhibitor story would be if we can augment them with milrinone long-term, we may allow the heart to heal a little bit more without putting in a VAD. And it appears in our situation, we actually send people home on long-term IV milrinone while they're waiting for a VAD. The problem is IV milrinone in a pediatric patient has all sorts of complications of line infection, thrombosis, and you use all your vascular access sites. And so something other than an IV formulation of a phosphodiesterase inhibitor might be an attractive novel therapeutic strategy in these kids, given the fact that they seem to have beneficial changes at a molecular level. They don't appear to have any increased risk of sudden cardiac death. We've sent, I think, 55 kids home on IV milrinone and not had a single sudden cardiac death event.
Yeah, another question, Lucy?
Beautiful data. I was very impressed by the huge decrease in alpha-myosin heavy chain protein in your pediatric heart failure without major change in the beta-myosin heavy chain. What is the overall level of myosin heavy chain? Do you have a reduced level of myosin in these patient samples, or there is no change?
No, the total amount of myosin heavy chain by Western blotting didn't change between the samples. The beta-myosin heavy chain by RT-PCR is a bit difficult to determine significant difference. You have to use a very large a very large sample size because there's variability within clinical populations. If you use mice, it's a lot tighter, but patients are so different, even when they have a similar disease, that the variability within your population is too large. I think if we would do a larger sample size, it's likely we would see something with the beta.